All right. Welcome everyone from the South Asian Bioethics Community. I think we're meeting almost after 7 to 8 months after we had this brief pause for multiple reasons, but we're really glad to be back, and we have our very own Supriya Subramani with us. I'm Sualeha. I work at the Center of Biomedical Ethics and Culture in Pakistan, and we formed the South Asian Bioethics Community back in 2023. So we've been there for like the past 2 to 3 years now. And we're right now working together and on certain papers that talk about the South Asian bioethics community and the importance of building such networks in sustaining academic collaborations across borders. Today we have Supriya Subramani with us, and whose book we're going to be discussing. And we have Priya Sharma from India as well, who will be the discussant, and I will serve as the moderator for this session. And to very briefly introduce Priya, because then Priya can probably introduce Supriya. So Priya is right now working as an assistant professor at Manipal Academy of Higher Education. She's an interdisciplinary scholar who's working across anthropology, sociology, and philosophy. She has a PhD and a postdoc from IIT Bombay, and she researches the issues of ethics and justice in surrogacy, midwifery, respectful birthing and mothering, and researching across essentially a lot of disciplinary boundaries, something which she struggled with, but I think that's where her strength actually comes from. So over to you, Priya.
Thank you so much, Sualeha. And yes, we are back after so long due to all the socio-political issues, but we are here. We have sustained, so that is great. I'm so happy to be here and to introduce to all of you Dr. Supriya Subramani, who is the founding member of South Asian Bioethics Community. So we owe it to her that we have this space. She is a lecturer at Sydney Health Ethics, University of Sydney, and a scholar of health ethics, philosophy, and qualitative inquiry, whose work engages at the intersections of embodiment, structural injustice, moral emotions, and the politics of knowledge. Um, Her research examines moral emotions such as humiliation and concepts such as disrespect, othering, and belonging. And a lot of that is something that we are going to discuss today. So, before further ado, I will begin the book discussion. So, welcome, Supriya. Welcome, and thank you so much for being here. And thank you for doing this once more. I know we already did one offline thing in Bangalore, and I happened to be in Bangalore. So I was there. I was very happy that I was there, and I'm very happy that we can do it again online, because for those of us who couldn't be there in person. So thank you so much for agreeing to be our first guest as we restart SABC program. So the book that we are going to talk about today is called Passive Patient Culture in India, Disrespect in Law and Medicine. And this book has been published under series of Routledge Research in Health Law. So what Supriya has done in this book, she has looked at law and medicine and has tried to make us understand this archetype of passive patient. So I will first begin, Supriya, with the title of the book. So how did you kind of come about with this archetype of passive patient? And then, of course, we will move ahead to what do you mean by situated patient that you're trying to situate later. But first of all, let's begin with the title.
Right. Thank you so much. First of all, it's just an awe, it's like feeling at home and then talking with your own family and then friends. So this is like really nice that we have this opportunity to do it again, and in the online format. So more of the conversation happens. And I must say thank you, Soleha and Priya, for this, to have this conversation push us through in different ways, and the opportunity for me here, definitely. And to answer your question about the passive patient, so I started way back. I mean, it's always I tend to go back too many long stories. That's my thing. I have to avoid that. So I'll keep to the time. But the questions around when I started my work during my PhD on informed consent was the entry point for me very often to start with the questions around what is autonomy, because I was working in a Wellcome Trust project on autonomy, and then how do we understand this question started, and it made me, the more I listened to general physicians, surgeons in India, especially in Chennai, that was my field space. It's strange to use the word field, but but having lived there, I moved from Bangalore to Chennai, but then having any person living in India, especially who access to healthcare experience, especially those are marginalized, you start questioning yourself like how we are situated within the larger socio-political conditions, right? So the idea of passive patient came in the moment when I read this Samira Kohli judgment, which is one of the Supreme Court judgment, which in the second chapter of the book, I unpack it much more. And the in the case, which is basically, which goes through around basically the doctors knows best or doctors knows best is the approach which current, the law or the legal judgments uphold and which continues to be, and it is a UK, which we continue the colonial continuities exist where patients are seen as stupid, incompetent, or people who are poor. There is an idea of Indian patients who are poor, stupid, incompetent, are so passive. So there is this, these terms keep evoking, and then there is a larger narrative keeps developing across the judgment in itself. So like how judges perceive who are we talking in India, who are this population, that is poor patients. So we need to, they don't know better and we need to take it. That is the doctors knows best. So the patients should trust. So that's an idea. So then the second part for me is about the narrative and rhetoric, which happens in the larger space of bioethics, which I was, I just came right into it and I started reading the literature within bioethics space, right, where it is Beauchamp and Childress works, which people talk about, and then like classic literature within the autonomy discourses and informed consent discourses, where the idea of a patient was much more of as if it's very, very, very plain, or as if it doesn't have in itself any kind of an understanding, and it's an active patient at the same time. While there is this clear ideas, patient is a vulnerable category, one that exists. And then there is an aspect of active patient, that is a patient who is competent, who can make decisions, who has all the agency, right? So this is what I was working with as I was listening and reading and engaging, and also having lived experiences and with many who go through healthcare system in India, and then reading the literature around this much more liberal, individualistic, but at the same time, who the self, the idea of self was very interesting, right? That's what I keep unpacking. But it's an active patient, which that the center of self is like who knows, who is perfect, who is very competent, who can make decision. And I think that's my, the unpacking which I wanted to do. And I took it as an entry point to reflect deeply, or at least take whatever the taken for, granted notions of what it means to think of a patient in India through the legal lens and the medicine, and especially the healthcare interactions.
Mm-hmm.
And its passive patient, I wanted to say, is an imposed version, right?
Mm-hmm.
Indian poor, or irrespective of whether it's India or anywhere, the idea of poor patients who can't make decisions and they don't have autonomy and agency is an imposed version. And I think that's what I was trying, at least I tried to do this in book, and it's an attempt to unpack that and critically question where this idea of passivity comes in. And my answer, as you could see in the last, is more about the way we don't treat each other humanely. So it's like basically you don't respect persons. I think that's where the culture of disrespect I unpack along this lines of thought.
Mm-hmm. No, and then that you mentioned already your entry into bioethics as discipline, right? And I like Sualeha mentioned about my work. Your work also is across disciplines. You've done what you call critical ethnography, with philosophy also embedded between that. So, and you don't want to call yourself a philosopher. There are a lot of layers there, but I would first want to understand, because see, bioethics is also in the name of our community, but bioethics is something that you are really uncomfortable with. So I would want you to reflect upon the idea of autonomy in
Right.
bioethics, and then what relational autonomy does to that, and why both are not suitable for what you're trying to do, because that is the narrative that you build. That even with relational autonomy, you are not able to get at the actual disrespect or dignity, and what you call later recognition. So
Right.
that
Right.
space. So I just want
Yeah.
you to reflect upon that, because this is bioethics community, right? So let's be
Right.
self-critical.
There's so many thoughts I had the moment you asked these questions. First, I certainly feel very challenged, or I mean, this is my existential crisis, and it keeps going back and forth. The moments like what's happening, genocide in Palestine, the questions which we have to wrestle within at different layers, whether institutions, personally, and the way the academics have have been silent, but at the same time, people who have set it out has used it as for their own benefit for their career in the moment, in the name of genocide, right? So all these questions already was back when I was reading and engaging in India on the classics, or whatever we call it, within the neat disciplinary boundaries of bioethics. For me, the difficulty started a long time back. It's not just with the present, it's an ongoing one, and that's the discomfort I sit with. And so there are moments I thought, should we keep bioethics as part of a SAP community? There are moments I've thought about it, because sometimes it can be very exclusionary, right? And for me, I feel that exclusionary part, the reason is that it's a hugely a theoretical, at least it's like, the philosophy leaning kind of a work is seen as something, an abstract, decontextualized versions of theory, right? So much of the analytical theories and philosophical leanings are the ones are upholded and seen as something good enough, intellectual enough, theory enough, is what the larger bioethics disciplines, at least the discipline which I have been engaging with, has made me feel. As simple as like when you submit to a journal with your lived experience narratives or experiences, it's seen as not enough, it's not intellectual enough, it's not theory enough, it's not philosophy enough, right? That kind of conversation keeps happening. The other comes with the theory of autonomy in itself, right? The second part of your question is, I think it connects to the kind of exposure I had, which again, as I said, I'm not philosophy trained, because I didn't do anything undergrad or masters where I started reading of Kant or all the classic literature which did white men's world, right? Which I only got exposed later. As I was reading, people say, hey, you need to read Kant because he talks about respect. I'm like, okay, I started reading about it, and I was unable to resonate with to the depth which I want, even though I use it for different purposes at different stages of my, thinking, and then the unlearning part for me. So the idea of autonomy, much more of the discourse in bioethics, is like making your decisions, like very clearly, like you need to have an autonomous decision. That is, as a patient, you are an autonomous being, an individual existence, and you make decisions irrespective of a very idea of detached self. You are independent, you're a competent, and you make decisions. Then comes a lot of critique around these questions, and that's a feminist literature. And again, I started reading more of relational autonomy discourses, and then also different critical scholars who are questioning the power, who is thinking of relationships. And again, much of the relational autonomy discourses, for me, what was the challenge is, again, there was an assumption that the self there is still very much connected and already assumed to be not threatened, by the dignity is not threatened there. It's already like, hey, the self is very coherent, and you make decisions in relation to the relationships or into the context, right? Those two were still part of it. And at the heart of a person's dignity was not yet, the political recognition was not perfectly captured. At least that's the reading which I started doing. And the more I started moving towards reading around the questions, especially recognition theorists, and also as I maybe started growing and thinking out in different ways, or my own unlearnings, I started thinking of liberation philosophy. I think that's where it comes off. Like, how do we talk? So I thought reading Ambedkarite, discourses and Ambedkarite philosophy, especially anti-caste discourses, comes through. And I'm like, I'm sure you see in my book, I don't do that unpacking well, but that's the value which I want to embed, right? And so that's where that pushed me to think through. And then I started reading Axel Honneth's work on recognition. And that allowed me to, okay, I don't want to talk just about decision making. I don't want to talk about decision making in relation to just the context, because when you're not even seen as a person experientially in everyday life, when your dignity is not just taken for granted in these discourses, then what does it mean and to recognize a person there? And that means patient here, of course. I mean, I use very patient and person as almost interchangeably. And again, in my view, the way I was looking at is patients who are marginalized, not just because of the category of patient, but because of marginalization already, because of larger social political condition, whether it's because of your religion, because of your caste, because of your gender and sexuality. So it's of course intersectional. I think that's where I wanted to think through. So the moment, whenever we teach ethics, clinical ethics, or any other bioethics, the target population we always see is a patient as already a vulnerable category, right? When you assume, and most of the cases, like there is a patient and then you go on with your case. And then the idea of in the patient is not unpacked. Who is this patient? Because it makes a huge difference to how the conversation leads to, the ethical questions which leads to. I think that's what I'm trying to do, I feel. So that's the way I moved through, I would say. I don't know whether I responded all your
Yeah, I
questions.
know you did, and we have time, and we will have more time to unpack some things in Q&A. You did mention about Samira Kohli's case while sharing why and how this title. Would you want to throw some light on that for our audience who might not know? Because that is a landmark case that you build your narrative around. So yeah.
Right. So Samira Kohli case is, as Priya you said, it's a landmark case, but it's part of the Supreme Court judgment, which clearly mentions that. Okay, before telling what it mentions, it's like the case is about women who had severe bleeding issues, much more of the gynecology issues. I would say had a like a lot of bleeding, right? And then this person went, this was happening in 90s, by the way. Right? I just wanted to acknowledge the timing. I mean, the time is also crucial to understand what it means and also to understand the present. So in that time, the patient has went through and then was giving, having discussion with this person saying that I'm having this, shall we just do more of a diagnosis around what's happening with the bleeding, severe bleeding? And then this person says, yeah, sure, let's get the, laparoscopy done and let's look at the whole issues around around what's happening. And this person, without the consent of the patient, this person is around 40 years old woman, cisgender woman, as I understand from the judgment, who's not married. These two are the crucial things to make it, because the doctor, surgeon, who is also another woman, who basically decided, anyway, you're not married, why do you need uterus? So on when she's unconscious, they took the permission, that is consent from the mother, to remove the uterus. I think that's basically happened. And then this was the initial reason why the conversation started. But interestingly, if you read the judgment, the case was brought not by the patient, even though the patient was pissed. The doctor went to the high court, or the district court, saying that the patient didn't pay the cost of the surgery. I think that's how it started. And then the patient said, I was angry, right? And I'm not going to pay you because you didn't get the permission. I didn't give you access. And the conversation is interesting when you look at the judgments, like how doctors perceive this person, and also the judgment, again, the judge. It went to high court, multiple layers, and even the Supreme Court judgment, I remember discussing with other lawyers in Bangalore. Jogarav, I think, was also in one of the panel during the book launch, right, which we had.
Yeah.
They're all progressive and liberal judges, but we know how in India many of the judgments are, right? And it's like, so it's like, yeah, in India, again, that's the whole narrative, like, which ties back to my work or the book and the conversations which we are having here, is in Indian patients, poor patients, they're incompetent, stupid. You just need to listen to the doctor and you need to trust the doctor. Again, this is nothing new for it. We know all this is the case, right? And this judgment is still the same. It is upholded till today. And now the question for me, or to think through, is like, how judge, or the judgment, or the law, or especially law, which is supposed to be protecting, whether it's when medicine is supposed to heal and care, and law is supposed to protect your rights and protect your agency, allows your larger patriarchal values, allows the certain gendered misconception that a woman who's at 40s don't need uterus because someone else decides for you, right? I think this is at the heart of how the patriarchal values, along with authoritarian ways of and authoritarian values, in the name of tradition. And again, what I'm saying is, if we look at the bigger picture of what is happening in the current climate, is again, it continues to perpetuate harm for people who are marginalized, and people, right? And those who are at the receiving end of care are more dehumanized and their agency is taken away. Yeah, I think I went along with different things. What was your question, Priya?
No, it was about Samira Kohli case, and which
Okay,
you
right.
have
So did I?
pointed out too.
Okay.
Yeah. That why that
I'll,
case became important. It was not just because of the nature of the case, but also the nature of the judgment, which
yeah.
was there. And interestingly, the like you said, it was not that the woman filed the case first; it was the doctor who filed the case. Because apparently, while rereading the book this time, I, Ritash, and Roshni, we went to the judgment. Actually, we looked at the judgment,
Nice.
and it turns out that along with uterus, ovary, and other, like almost all the organs were removed, and it was the would-be husband of Samira Kohli who actually uh, took her from the hospital, and then doctor put a charge that they left and that person disrespected us, and then has not paid the bill and all of that, and was very angry. So Ritash had this very good point, and I'm sure during Q&A that we'll bring that in, that also who was making that, like, of course, this idea of the husband figure also coming in and trying to do something, because apparently the judgment says she was about to get married. So she said that I was about to get married and you never told me this and you never took my consent. So all of that is there, but it's actually very interesting to read, and everything is all available on public platform for others to read.
Very
But it
true.
makes sense to understand why you chose this case, because though the judgment looks very very for people, but the language, when it is trying to be empathetic, is actually very, driven by pity
Yeah.
towards people who don't know enough.
I
So be
think
it
this is the
women, be
elitism and
people at
the upper,
margins.
yeah, no, it's elitism and then upper caste values and coming through in different ways. And I see this as, I mean, whether irrespective of whether the person, the patient, we don't know about the caste or anything, but I see that value system coming in different ways, right? It's an approach that, and again, this is like a generalized idea because the judgment is given in the notion of the much of the population. And the
Yeah.
idea of much of the population are basically, the stupid, incompetent, we need to do good. That savior complex is part of the journey into making this judgment, I would say it as. And that's norms, which reflects much of the conversation and which continues to even in the current judgments. If you look at the rape law, and the sexual harassment cases, I mean, and then the marriage, I mean, it's all connected, right? The value system in many ways, how women are perceived, and also who is perceived to have a voice and who needs to be heard and not heard. And I think it keeps coming through in different legal language, especially in the judgments. The
And in
paternalism
this,
is strong, of course.
yeah. And in this chapter, I also remember it's a very thick chapter, by the way, not like for the faint-hearted. It's very thick in terms of you actually unpack what informed consent is, where did it come from, different cases, and where we are in India. So do you want to just reflect a bit on where we are in India in terms of, do we have a law or do we have guidelines which tells us what is informed consent?
So in India, we don't have informed consent legally. We do have it in practice. What I mean by that is within the hospitals, especially in the corporate hospitals, and maybe even some of the public hospitals, you do sign a form, right? That's a consent that's called real or valid consent. So basically, it's more of uh, it's much more of not that patient consents for this. It's more like the doctor gives you option and then you consent for certain, especially the bodily integrity is at the heart. So for instance, if anything happens to you, the criminal negligence, like, but again, you can't sue them. I mean, again, maybe I have some limited understanding of this. You can't sue doctors from the public health hospitals. You can't sue them because they're providing free services.
So yeah, that was another point. That point comes again and again because you have in your, and that is where the next chapter comes in, because you've gone both to the government hospital and private healthcare
Yes.
spaces. And you also compare the two. Like in government, there's this idea that this is anyway free, right? And that doctors are, and you also address and acknowledge the fact that, of course, doctors are always overburdened. There is limitation of resources, but that shouldn't become an excuse to mistreat people. So a bit on because there are multiple cases. I remember you've given it's fantastic ethnography that has been presented to us as readers. I remember multiple instances of with, say, a nurse or a doctor, and you also look at the nurse and doctor hierarchy. So I think there are multiple things there. So the first thing that I would want you to throw light upon is the distinction between the government hospital, where it is all free, and private where it's not free. So to the patient feels that they can ask questions, but still they cannot. So between government
There,
and private first, and then we'll go to the further hierarchy of doctor, nurse, and patient.
right. Yeah, there's so much there, right? I mean, so the reason why I wanted to first of all, to get access to the hospitals is not easy to do research, which I did. It
Yes.
took me 1.5 years to get the permission, and then of course to tail behind the bureaucrats to get it done, and then get permission that I wouldn't be recording, but I'll take notes. There is so many. Of course, we can talk more about the methodological challenges and ways I work through that. But the reason why I wanted this to experience is like I had all my life, I had experience when I was growing up with my parents. Much of my life is access to government hospital and private clinics. That is, tiny clinics in the rural areas, like where some of them are, most of them homeopathy. That's where's my experience and access to. So, and only there was a couple of instances where I had access to the Apollo because again, there's a long stories. When you go through extreme, then you don't have choice of government hospital because of the long queue and that kind of a waiting period where you get discriminated and dehumanized at Nimans, which I had experience, or even in different kind of, okay, I don't want to mention the names probably, but different, government hospitals. And then when you go to the private hospital, there is a different set of group, right, who access private hospitals, especially if you're looking at relatively in the main city areas, like in the Bangalore city or in Chennai city. You look at people who are relatively have money, right, and who feel much more freer to ask. I'm not saying that they wouldn't be pushed back, they wouldn't be resisted by the doctors, and like, how dare you ask me question. Definitely there are so many instances. I think that's what I unpacked that in the chapter on, right, in the everyday indignities aspect. But I want to bring in the contrast of how in both cases where there's a highly educated patient and who has money, who feels like you are entitled to this kind of a care, right? You go to the private hospital, but you still are seen as like, how dare you ask me questions? So there is something which is happening not just with the education, because you remember, go back to the judgment. The judgment basically says is like, in India, poor patients, no education. So that is contradicting. I want to show that aspect of. So it's not just about education, it's not just about the money, right? Then comes the private government hospital patients. It's much of the experiences witnessing again and again, and many of you, I'm sure many of you who are here have experienced this. It's nothing new for people who experience government hospital, either as a provider or at the receiving end, where the everyday dehumanizing is part of how you expect that system would function, and you're already trained into expecting this is going to happen, and then you work with that system, right? You go, unless you meet some of them, you are a regular patient, then the experiences are different because you're familiar with certain healthcare providers, whether it's Aya, whether it's doctor or a nurse. It depends on how you build the relationship. If you're a chronic pain patient, it's a very different story again. I mean, there are different snippets it comes through, right? And that's where I say situated patient discourse is important, because it gives you a different kind of worldviews. But much of the narratives of when I was listening to patients in government hospital, like to, the hospital patients, where like, is like you're constantly dismissed and disregarded. Again, this is nothing new for us, right? We know this is the case. The question for me was much more like how people navigate when you are disrespected and when you know this is going to happen to you. And for me, that's where I want to bring in the resistance aspect, that especially I give an example of my mom or my in different ways, how you are dehumanized and you're questioned. At the same time, there are moments your silence is a resistance because you know the system treats you. So basically, you just shut your mouth, get what you've done, and then move, because you don't have a choice to go to private house because of the money, right? You don't have access. So this goes back to the fundamental, again, question of health is politics. And then again, the structural injustice, which creates this space where you want to go to the larger healthcare system to heal or care, but then you're harmed more. You're dehumanized, right? And that's a hit, and you trade off sometimes, and sometimes you don't. It depends on how you have bandwidth or energy, I think. And that, I think that's the narratives which I kept having conversation with many people. I think that's what I was trying to capture. And then the the private hospital, as I already mentioned, it's again with different, like gender plays a role. All the intersectional factors play a role in how much people ask questions or resist, right? But in both, the stories are same, that doctors feel irritated They feel, how dare you ask me questions? So there is this huge resistance that patients can't ask questions. So that goes back to the whole idea of where is this active patient we are talking about? And that's the whole bioethics or the health ethics space, which assumes that patient is an active patient who is competent, but then everyday human dehumanization doesn't even allow you to ask this question. So it's ingrained moral norms and as you know, the ethos, which is partly institutional, right? Whether it's government hospital, whether it's private hospital, but there's a larger ethos of that power asymmetry is so embedded, you take it for granted that as a patient at varying degree, I am going to dehumanize you in different ways. And for those who are marginalized, that becomes worse. And especially if you are from a lower caste communities or from Muslim background, like I'm sure we all are reading again, I'm not saying that healthcare professionals are not experiencing, especially who are marginalized, they experience, the system basically behaves a way to dehumanize everyone. And then the larger question is, how do we want to talk about dignity, especially, I talk about true dignity. How do we talk about true dignity in a context which completely dehumanizes you and there is inequalities across?
Yeah, so given you have already touched upon that, that was my next question, that you unpack what a true dignity would look like. That is also one of the critiques that you build upon relational autonomy work, and you say that even and some other works that you point to, which are social justice based works, but you're saying you kind of at the end you say that if we need true respect and true dignity, we need to centralize the concept of recognition. So I would want you to speak a bit on that, and maybe with that, before or after, how do you look at the concept of epistemic injustice?
You're asking me that question of epistemic injustice, right? So I think how do I look true dignity as? I mean, I think like every answer which I can imagine is conditions where poverty would allow you to, I mean, see, this is a challenge, right? On one hand, I'm not saying, or I don't want to say that people who are in the conditions which is oppressive conditions don't have dignity. Please don't mistake me for that. That's not what I'm going to say. But within the larger oppressive conditions, a true dignity can be only exercised when we recognize each other and especially don't degrade one's self-respect. I think that's the concept which I go back to. And I think the self-respect movement discourse comes from a Dravidian movement, and especially Ambedkarite philosophy and Periyar philosophy, which you center the self-respect. And that's where only when you recognize and acknowledge one's self-respect, I think that's when the true dignity can be seen. And how do you do that? It is not just within the healthcare. Because very idea of healthcare is what we always talk about, doctor-patient relationship or within the healthcare professionals. We need to step and look at the larger systems and larger systemic issues of freedom, social freedom. And I think it's connected to justice at the heart, right? And how do we talk about dignity? And that means justice is at the heart. It's the way I see, and it goes hand in hand. And again, the question is justice. How do we do it? Is much conversations altogether, but it's across everywhere. It's not just within the health space. It needs to be happen in health. Education. It needs to happen in different spheres, interpersonal, family. The larger system level, and also as bare minimum, having more resources. For example, as simple, sometimes it's important to recognize that the country like in India, we need more resources. And again, that's larger questions to think about. And again, answers with economics is like increase the budget. I think sometimes that's also an important, but also it's a values. Like how do we perceive? I think that's what I want to go back to. The way the law functions, the way the medicine functions, assume that people are passive, that they don't have agency. And I think we need to first recognize and acknowledge there's already a resistance. A person feeling humiliation is already showing and crying out loud. Like, when I'm the stories of dehumanizing, the stories, the narratives of humiliation, shame, which it shows is a part of resistance, and we need to recognize that as the first to start with the movement, if I would say, as to bring the true dignity into the system. And what did you ask me? Sorry, Priya, what was the next one?
Epistemic injustice.
Right. So many people are talking and writing about epistemic injustice these days, right? But it's still certainly at the heart of knowing part, right? Like recognizing that each other, especially who are marginalized as you don't know. I think that's at the heart of passive patient too. It's like patients who are poor, incompetent, are who don't know. I think again, the idea of injustice, epistemic injustice and structural injustice, which is part of it, is it's a circle which continues and it perpetuates each other. I would see it as, and I think I would see that is a reflection, and the archetype of passive patient is a kind of a symptom, or it just shows you that. That's my thoughts
Yeah,
on
and I
this.
think you're referred to also dismantle not just passive patienthood, which is everywhere in India, but also what is active patient, right? That the way that you're trying to say that, what do we mean by when we say active patient? So that dichotomy is something that you're trying to question by bringing in your concept of situated patient, which I guess adds to the, even when we look at the epistemic injustice part, adds to that set of resources which maybe people did not have to speak about this. Uh, and that's why it becomes important when you centralize recognition there. You touched upon the fact about how, and you've showed that through judgments, through the medical encounters, that people are seen as devoid of agency, right? They're seen as passive. But then there is another aspect, and we've had this conversation before, but of course we will have it again because we are here. That in my own research on surrogacy, I ended my doctoral work, and that's what I'm working on now. That how there is again a section, say for example, in my work that I found in my research, a section of Dalit feminist scholars who believe that there is no agency. Like for example, in terms of sex work, which they don't want to call work and they want to call only prostitution, or in surrogacy, and saying that we have to ban it because there is no agency whatsoever, because this is caste exploitation, there's so much structural injustice, and they bring in the concept of reproductive justice there, that because in reproductive justice we have to look at the structural injustice. Hence, if we look at it through that lens, how can we speak about agency? And that is something that I speak against or argue against in my work through ethics of care, which is again, though your work is at another axis, but it speaks with that. And in your work, you are trying to first of all say that the way the patients are always seen as passive is not right, and there is agency, acknowledging that there is structural injustice, right? So how would you respond to critiques like this, that coming from people with lived experience?
Right. So I think for me, the question comes is when a person or when a scholar is trying to say that don't say there is agency. I think they're referring, I mean, this is my understanding. Much of the reference is more of like when we are surrounded by oppressive conditions, where do you think we can have an agency? So I would see that as an opportunity where look at the structure and just like we are completely oppressed, right? I mean, but then again, this is where I would respond, would see it as while there is this larger oppressive condition, Serene Kader is a very interesting and amazing scholar. In different ways, she unpacks the global South scholarship, especially feminist scholarship, and she also recognizes this like how the agency is practiced and lived within this oppressive conditions. So, right? I mean, so it need not be the way the idea of agency, which is developed and constructed by a certain idea of liberal frameworks of idea of what agency is, what I was referring to here. But it's like a certain moments, the like example of like when I think about my mom is like saying you just go to the hospital, you just shut up and don't ask them, don't question them. You get them, you get out of this, because if you ask and if you get pissed off with the doctor and they wouldn't even ask you to, I can't go back there, don't do this question, right? Don't ask a question. For me, that moments is a reflection to look and largely question the systemic issues. For me, it's like how can because there are moments of navigate that experiences because you want to get what you want at that moment. But I feel that's a moment like people shouldn't be having those experiences in the first place of like to navigate those oppressive conditions. And that's to recognize agency at the same time as also reflecting the structural injustice. I think you don't have to do it as like this or that. For me, that's how I would see it as, because it happens and it's a reflection of the struggles together, and struggles for recognition is part of struggles for resistance, the way I would see it as. And that means agency. I mean, that's my understanding of agency is, yeah.
So I think we will now open for Q&A. Sualeha, let's just open the floor. And if we like, let's give others chance to ask you questions, and then I have one last question in the end.
Well, we'll open it
Lovely
to the
questions.
to the rest of the audience. I want to give others a chance because we can catch Supriya anytime. I have a couple of questions as well. So, uh, yeah, I think Ritash, do you have a question? Sonali, do you have a question? Yeah, I think Sonali does. Go ahead, Sonali.
Sorry, I'm also eating. Thank you, Supriya. I am yet to read your book. So I work, I'm a doctor by background, but I don't do clinical work anymore, partly because of certain experiences I had during internship as a provider, and I wanted to improve the system. And so I went down this track of what is called quality improvement. And some of the things that you said in relation to your work resonated with how I've been thinking about what we call quality improvement, which is basically teaching healthcare providers how to improve their system. You mentioned that it's decontextualized. So I forgot what you were referring to, but it spoke to my work. And have you had an experience in talking about your work with healthcare providers, doctors, nurses, and how has the reaction been? Because even though my work is much more value neutral, which is irritating, um, I get a lot of pushback. Oh, we are doing our best. यहाँ तो ऐसे ही होता है, ऐसे ही चलता है. So I think the passive patient and I think there's sort of a partnership between the healthcare provider who has apathy. The apathetic healthcare provider combined with this notion of the passive patient, which you're critiquing. So I don't know where I'm going with this, but curious to know what has been the response from healthcare providers on your work. Yeah.
Right. Thank you for this. I have got different responses while I was doing my PhD and when I was presenting at different conferences within India and also when I went out. Couple of experiences I'll share with you. Some during in the interviews, like the first question, I think many social researcher was outside the system. That is, when you are not a clinical profession, they're like, "Who are you?" That's like a first question, right? That's the first interaction. That's how it starts. And then you start unpacking, and there is a power asymmetry already between a doctor, especially if you're meeting a surgeon. I think I have had so many experiences where you sit differently. Especially when you're talking to a male surgeon, again, there's a lot more that power play you need to do. Sometimes I became passive in order to get what I want to get, kind of a conversation. But interestingly, during those exchanges and conversations, the more I think about it at different stages of my career as it went progress, it's more of one, how dare you ask me this question? Second, we already are practicing autonomy. And the way they quickly
Mm.
switched is by saying that we take consent form. So what you are expecting more than this, we already are practicing. And this is especially within the private hospital. Within the government hospital, we are this benevolent doctors. How dare you ask this question? First of all, I never asked the question, do you disrespect? That was never my question, right? It's more of, tell me more of how you think about patients requesting information about operations and surgery. So it was much more of a discussion around information disclosure. And the way the conversation went, which is a very common theme, it kept coming across, is like these people, they assume that I'm coming from the same class background. Because I was from IIT, I did my PhD from IIT. So there is this inherent, that kind of a signaling which happens, not necessarily with everyone. In some, it has went the other way around too. So immediately they're like saying, oh, these people they don't know, we know better, right? Like, the kind of a reflections, right? So that is during during this interactions and listening to different surgeons, but not all doctors are like this. But dominantly are like this. That's, I would say. Then comes later when I was sharing this information. So one of my practice was like to go back to the community, especially in the private hospital, which they gave me a space to share with them this whatever I had. And they were like, you are not understanding healthcare professionals' experiences. You're not even taking into account. How can you say this? You don't listen to our struggles and problems, which I agree. But I keep responding to them that it's not about time, it's not about resource, the way you treat patients. I think that's my beef with you. I think that's what I am right, like that. So we have had this very difficult conversation with some, not everyone. And some of the doctors has been really, especially two of them who I don't know whether I should mention them, but they're very brilliant and they're very humane. I think that's where finally it comes to how humane you would want to be and then acknowledge and practice with humility. I think that's at the heart. And there are amazing doctors who I met and they responded it in a different ways. Then comes when I went and presented in abroad, some of the doctors or public health professionals who are from India, who were also in the same conference, they said, why are you talking about India in this so bad way? Right? They're like, almost like it's our laundry. Why are you coming and showing that kind of point? So it's like, so you feel like you're not really recognized and acknowledged within the system. On one hand, what I wanted to say is there's so many different responses. I don't know whether I reflected on anything which
Yeah. Thanks,
Thank
Supriya.
you. I just feel it's very courageous. It's very courageous work, especially going back and talking to people
with
about
few of
it.
them I could.
And I
And other
do
thing is,
hope,
I'm sorry. Oh, I think I have this
if there are, I hope there are more avenues for you to engage more widely with healthcare professionals, because that I feel is
Right. And I think after the book came out, like I got a couple of angry emails from healthcare professionals, particularly homeopaths, that I didn't, I'm not doing Indian work properly. Yeah.
Yeah. So I think, I mean, we can resonate with a lot of these things, what you're saying in Pakistan as well. And in terms of like what you said about public sector hospitals, what the usual response of doctors generally would be, it's very busy for us, and, but I think what you're saying in terms of, humility and, how you demonstrate just basic compassion, I think, which doesn't take a lot of time. And I think it is this exclusionary practice of say that these are the people that we are doing a favor upon, right? That is the hard, because I work in a public sector hospital, like the center is situated within a public sector hospital. So we listen to these kinds of narratives as well. Now we have a question from Pakistan, actually. So, and by a doctor, by a surgeon. So,
I think you're muted. Yes.
Sorry, I'm the only one, I guess, singled out as a male surgeon. And in company of, if you don't count Farid, I'm the only male over here. So I'm really scared over here now. And what you have talked about, of course, I've not read the book yet. But what you've talked about is resonates with us. But being a big bad wolf, who's been doing all of this kind of stuff. So I've trained in the public sector, government hospital, and I've seen what you're saying, and I've actually practiced what you're describing, and then I've worked in a private sector also for a very long time, and now I'm back in the public sector, in the government place. So while I mean, you're quite right about the attitudes and the lack of empathy and the lack of sympathy. And we are very compassionate and kind when we go home or in a different company. But when we come in the presence of patients, we become these bad, awful creatures. So why is it that this transformation takes place? Why do we become from some normal human beings into these vicious animals who are actually trying to heal people? There are many reasons for that. I'm not going to go into that, but yes, this transformation and this flip-flop does happen. Environment does make a difference. However, we also look at what our mentors have taught us. So there's a huge hidden curriculum that we are following. While we are taught, when I was a medical student, we were not taught bioethics. We are now teaching bioethics. So we are hoping our students will be a little better. However, we learned from the best, and the best were the worst in the sense of manners, the bedside manners, etc. They would expose patients, children, adults, everybody else. They would be exposing them for examinations without asking, and that's what we learned, and that's what we did also. We would be using patients merely as a means towards our own education and education of our students. And if things go wrong, Allah ka karna ye hua. It's good God that did that. If it was something that goes okay, so I've done my great job. So you take all the credit for that. But you spoke a little bit about consent and how it doesn't seem to be playing out the way in both private and public sector in India also. So that again is a practice, like my practice of taking a consent when I was a medical student and a resident was, as an intern was. There was a strip of paper that I would just tear from my notebook, and I'd write in Urdu that I am taking, I am from on behalf of the patient. I would write that I am permitting this doctor to do any kind of surgery, any kind of anesthesia, and nobody will be held responsible other than myself because it is my choice. And there's a thumb imprint which may not be the patient's, it may be mine or somebody else's, and that would be valid because that is what we learned. However, what we learned later was that whether in the public sector or in the private sector, I was equally answerable to law. The law was the same. The regulations were the same across all sectors because it was the patient and the process of the interaction. However, both I guess as in India and definitely also in Pakistan, if you look at the older generation, they were set in their mean ways, and that's how we learned, my generation learned. But as we've learned, going back to the classes and the theoretical work, I think we've been able to, with the inclusion of bioethics in curriculum and in practice, what we're actually learning is that these things are getting internalized. There is some aspect of at least these procedures coming into it. So informed consent may not be a morally valid informed consent, but it'll be certainly a procedurally solid informed consent where all the boxes ticked. The pressures on the doctors, and I'm not defending mean doctors, but I'm saying the pressures, the numbers that they have to look at. I mean, we're looking at 300 patients in the same sitting, etc., are also not conducive for good manners, etc., and good way of behavior. So all of these things do add on to making good people really ill-tempered and bad-mannered when it comes to interaction with patients. So I'm sorry for taking it too long, but I think this is what I wanted to say.
Right. No, thank you for reflecting on. I mean, there's so many things, and there are definitely which it's like you're spot on the hidden curriculum. And I think in some of the aspects which I also in my earlier work and also in this book, I show this larger moral habitus, at least the language which I use is basic to capture this how each institutions have their own culture within the larger culture, right? And then when individuals, especially healthcare professionals with have power, you walk into the space and you perform in certain ways. And one of the performance comes through the larger hidden curriculum, which you're embedded in the larger context. But at the same time, you allow oneself without reflective practice, like how each moment of your practice with a patient, with a family member, you're not even taking a moment, let's reflect, how am I treating this person? Because it becomes so monotonous, along with addition of how high pressure and then lack of resources, all those factors play in certainly. But this is one of the moment which I always go back to whenever I had this conversation with some of the surgeons. I'm not talking about always. I don't want to stereotype surgeons, right? But the conversation keeps happening is like when you meet. I mean, this is something which I've witnessed, right? Like when you little bit relatively you're dressed up and you carry a certain social marker, immediately a doctor, whichever gender, whichever class, whichever thing, immediately they perform differently, they react differently, they treat the person differently. Whereas a person who is basically considered with the social markers, you're a lower caste or from a certain slum community or a cherry or different categories which you impose on this person, whether the person is able to resist or question, you forget about all this. But then you push back, right? You don't even respect. I think that's the culture of disrespect we completely have taken for granted and normalized so much. And I'm not saying this is only the hospital or the healthcare settings, right? It's part of the larger culture. I think this, if at all, if there is something which I want to share in the book, which I keep bringing up again and again, is it happens in schools, it happens in banks, it happens. So this is like a culture we live in. And healthcare setting is another, institution where we perpetuate harm and or like we embrace the culture of disrespect in a way which doesn't recognize a human, especially the person, and especially who those are marginalized. Just a quick reflection based on listening to you. Thanks for sharing.
No, I think that's right in terms of the larger culture, because in terms of social markers, because Fareed, remember you had something I mean, we were making this video on informed consent at CBEC, okay? And the person, so Fareed, would you like to share that? Because I think it's very interesting and how dressing actually makes an impact on how doctors treat patients. So I'm going the extra mile and kind of putting people on the spot right now. But I think it adds to the conversation and it adds to the point that Supriya is making.
Oh, sorry, you're muted.
You're mute.
So thank you, Saleh, for mentioning our latest video on informed consent and medical decision making. The public health one was not the latest one. So in that video, we had a colleague, and she is also a surgeon, and she was playing the role of a daughter whose father was incapacitated and on a ventilator, supposed to be going on a ventilator. So on the day we were supposed to be shooting, she came all dressed up and with all makeup on, very dressed up, like going to some party or a family gathering, something of that kind. So she was asked by our director, our professor, Dr. Mozam, that you are a daughter of a person who is on a ventilator, is about to die, and you are dressed up like this. What was going on in your mind when you were dressing for this shoot? So she said, being a doctor, but she also plays a role on the other side as well when she's going with her family members. And she said that doctors listen to you when you are dressed up properly. If you are not dressed up properly, doctors won't give you that much attention. So I think that's what Saleh was pointing to. I also have another question. I think it was, I think, a misunderstanding, or I didn't listen properly. You mentioned that you can't sue a doctor who's providing free health care. Is it so in Pakistan? Because I think this is a perception in Pakistan from the point of view of patients. Because I listened to a friend last week, and he was telling that some of his family members went for a dental procedure in a free of cost healthcare facility, and the doctor messed up, and then I asked, did you complain? And he said, no, how could we complain, because we got our that for free of cost. So is it just the perception, or is it a legal thing there?
You're talking about India or Pakistan? Sorry, just
I think you were mentioning about India.
India, yeah, no,
Yes.
because you asked, sorry, yeah. No, I mean, in India, as I know, whatever I have read till now, only if it's a complete negligence. That is when there is, for instance, a person has left seizures inside the body. I mean, this is the extreme thing which I'm talking about. When there's a criminal negligence, or when your bodily integrity has been, yeah, it's like a huge negligence. Only then you can sue. Otherwise, you can't, especially the public health doctor. As I mean, as I know and I've so far have read, I don't know if there is anything new information. It's not like just what perception, it's actually legally you can't.
But
That's
in
my reading.
Pakistan, I think you can. And I think Dr. Amir wants
No,
to speak.
yeah,
Yeah, and then,
it's uniform across for all
yeah.
doctors in Pakistan. If anybody who can be sued either in the private sector or the public sector, whether the patient is paying or not paying, the patient will not take them to court because it's just so expensive and so long drawn. Yeah, unless you have very deep pockets, you will not take them to court. That's a different thing. But the law is the same. Yeah.
Definitely, that's a punishment by process, right? And I think that's the whole kind of. But because I was discussing this with a law scholar who I was doing internship before I was, engaging with legal judgments, and whatever I learned from them is that you can't, because it's seen as free service, and free means you can't feel entitled. I think that's something which one has to really think through at how we think of rights, right? Patients' rights discourse, of how the ideas of frees or freebies in the current discourse, which is happening even in India, like how it's seen as like it's not your rights and it's not your entitlement in a way. So yeah, no.
Hi, I think we have a question from Lakshmi, and we also have a question in the chat box from Asmat. So we'll just take Lakshmi's question first, and then we'll go to Asmat's question.
Yeah, hi. I just would like to respond to the previous discussion and then raise my own question. I think, like you said, if you have to sue the doctor in a consumer court, then whether you pay or not matters. But in terms of criminal negligence, whether you pay or not, even the public doctors are liable. And I think the understanding of medical negligence has expanded to include lack of information, crucial information about the process. So I think right now it's also up to how the argument is constructed as a negligence. So lack of informed consent can be made as a ground for raising a case, putting a case on against a doctor. But I was wondering if, Supriya, you have looked at the Bolam test, because the moment you raise any argument that a standard has been neglected in my case, then the Bolam standard is kicked in, and the Bolam is based on the fact an average medical doctor, male white medical doctor would do. So then the solidarity among medical professionals kicks in, where the patient's perspective is completely sidelined. So has there been any development on that? Has your recent research shown anything that's
No, I think this is what exactly I wanted to highlight and center the Samira Kohli case is because Samira is a precedent-setting case, and the precedent is based on the Bolam case, which is 50s, 1980, whatever, the 50s case, and then you moved in India where this case Samira Kohli happened in 2008, and till recently, the recent judgment when I was engaging and reading up around is 2015, which is still the reason I was not looking at the much recent versions, but it still upholds. There is nothing has been which reverses this. That is basically what Bolam case stands as a medical professional standard. As you rightly pointed out, it's about people, how it is perceived and understood by the medical professional community. And again, they choose who is this medical professional community they bring in. And then much of the cases keeps going in favor of medical professionals, right? And there are moments where, for example, in Samira Kohli case, the judge did say that the person was guilty, but then excused by saying the rest of the judgment that the person needs to pay 25,000. The surgeon has to pay for the patient, but then excuse the whole question at the heart is about the patient's dignity or the rights or about the consent, not really acknowledged. They only focus on bodily integrity because it flipped into the whole idea of bodily integrity discourse, not around the questions of the consent, which comes through of bodily integrity and consent definitely has a relationship, but the right to information is never part of it. That's why it's seen as the medical professional standard. Yeah. No, there are no more changes. Yeah.
Unfortunately, yeah. And I think it's very different when it's a woman patient versus a male patient. So a lot of gender dynamics also kicks in. I'll just quickly ask the other two things. One is we see a lot of violence from patient and patient families on doctors increasing. So I understand the same structural factors actually are contributing, but would like to give a small section of an aggressive patient and what, the passive patient to an aggressive patient, and how the same factors actually, would you like to just give a reflection on that?
This is one of,
the second question is a very practical suggestion from you. What is one thing you want to see in practice changed in private or public health practice that takes that little step towards recognizing dignity of patient? Something very simple. So this is something that, like, say, a medical student or medical professional want to take home and start practicing from this evening.
Right.
So that's my second.
Right. And the first one, can you please quickly remind me? Sorry, I was looking at the chats.
The passive patient and the aggressive patient.
Right, thank you. Aggressive patient. Oh my goodness. So you remember last year, end of the last year, there was a case in Tamil Nadu, not case, but yeah, an incident happened where the patient person is a cancer woman is having a cancer patient, and her son and the mother both are experiencing everyday dehumanization and disrespect in the government hospital or in one of the hospitals in Tamil Nadu. Yeah, I think it happened in Chennai. And then the person got, the doctor was so disrespectful, the person, that is the son of the patient, got angry and then went and stabbed the person. So in the interviews, like I was listening to interview snippets here and there in the newspaper articles, and one of the thing which kept coming across in that, in the press release, is that the mother was saying, hey, I'm experiencing everyday dehumanization, the doctor doesn't listen to me, and then my son kept witnessing, it's out of love he went and stabbed the doctor. So why I want to reflect on this moment, there are so many instances like this, right? The reason why I want to see it as part of the larger connection of the culture of disrespect is that when you don't really recognize persons, like you don't listen, you don't engage, you are disrespecting a person, after a point, I would see, I know it's a violence, right? It's certainly a violence, but the violence is done by the system. So violence only creates more violence. The systemic violence, whatever is happening, and the violence against doctors or any healthcare professional is part of the system. And what happens in reaction is, in India, whatever I witness, and I think many of the public health professionals are sharing this, much of the public health professionals or doctors community come together to protect themselves, talking about the workers' rights or the workers' safety, or there are moments, of course, people talk about sexual violence and again, the safety of healthcare workers, but you're not looking at the larger issues, which is like this everyday indignities, this everyday dehumanization is part of the systemic issue, which the doctors are not actually pushing for, right? This is not being pushed to change you, because it's only like, let me fix my thing. So basically the idea is zero tolerance, that the violence, zero tolerance. And then there is a lot of what do you call, the bouncers in the hospitals. So this basically it's clearly shows that the system is acting more reacting violently towards the patients who are supposed to be cared. So there is different versions of the stories one can understand with the idea of archetype of aggressive patients. One is like, one of the things which I can think of is like, especially in the migrant health community where I work, and this is something which I'm also looking at here, like in Switzerland, I was looking at, and even in Australia, is like how patients who are already having mental health illness, already experiencing racial discrimination, already, like, there's so much of intersectional violence happening across, and then you come to the hospital, your reaction to even a little bit of aggression, sometimes it can be even anxiety. A patient can show a symptom of anxiety, it can be seen or perceived as aggression by some of the privileged doctors. And I think this is the same recurring theme which keeps happening, and it basically create the cycle of violence, I would see it as. That's something which is about the idea of aggressive patient. I think it's, again, we should see the symptom of a larger violence in the system. That's how I would see it
May I
as.
just interject over here, Supriya?
Mhm.
And I think the case that you talked about, because we've seen that happen again in Pakistan. I'm sorry I'm interjecting, but I think it's an important point to be made in terms of violence demonstrated against physicians is mostly by patients' family members. It's not the patient. So the case that you also mentioned, what you were mentioning, it was the family member who actually exhibited violence, and it does stem from disrespect of the family and also of the patient, or because when there is a disagreement in decision making that occurs, because either the doctor has not listened to it, and there's also reflects the larger trust issues that now patients are exhibiting towards the healthcare system, which obviously reflects to the larger structural inequalities that, Supriya, of course, you're talking about, right? And I think your second question, Lakshmi, and in terms of Asmat's question on the chat, or actually speak to the same idea, is that is there any particular solution to the problem, or one thing that you would like to see in terms of
Yeah, I was coming to that. So
yeah.
one of the draining thing in India, especially when you're poor, who have to, especially you're coming and traveling from rural area, like I think that's like complete dehumanization, waiting. Waiting, you don't know what's happening. I think that's a dehumanizing. It's like at the core, I feel it's your dignity is stripped at multiple levels, right? I mean, whether it's in the government hospital in Chennai, whether it's in Delhi in AIMS, or any high flooded, because of the bigger picture we have is we don't have resources, and resources with both human and active resources, material resources. so my small change, one is a reflective practice, that is like as a person we want to reflect, but also the systemic, that the institutional level for me is like, please fix the way, some ways to fix the waiting for patients, because long queues, again, you don't even know when your slot is. Like, is there a way? I mean, definitely there should be a way to fix that waiting protocol with humanizing experience. I think because it's like bare minimum, which we don't care. I think this again happens in our food distribution system again, right? There's so many things, because there's a systemic issues. Again, I wanted to say it's institutional at different level, and hospital is another one. I want that, if at all, if at institutional to be fixed, that at individual level, it's reflective practice and recognizing how you want to be treated. Again, this is like, seems like too much to ask, but it's not too much to ask at the same time. Yeah. So
So we have more questions from Sonali, so we'll take that. Yeah.
I just wanted to say on that, Supriya, there are methods and ways that exist to address these issues. So I work on things like reducing waiting time. And actually, from AIMS, there's an interesting story. One of the gynecology consultants, Dr. Aparna, she's actually reduced the waiting time for infertility treatment from an average of 2 years to about 6 months. So your fertility is reducing while you're getting treatment. And many, many other stories from nurses across the country and other places who have worked to improve their systems. The problem is there is no demand to learn how to do this. There is no demand to learn how doctors and nurses can actually work to improve their systems. So it's we get a similar pushback like you get, like ऐसा ही होता है, ऐसे ही चल रहा है.
Right. And also, this is a thing, right? Like, how do we work within a system, but also bring change within the system? But at the same time, how can we witness this, like as healthcare providers, walking through this long line of queue where people are sleeping or for days and things, and it's so dehumanizing to oneself too, right? That because you need to pass through every day. Like, it's like there's a part of me, I always like, how are we living with this with each other in this certain dehumanizing spaces? I mean, I think this can be asked for everything else, right? Whether it's the caste politics which is happening, whether it's the killings and the Islamophobia, what's happening in India, like with everything, and the fundamentalist raids and the bigotry across within family. Yeah, we can keep asking this: how can we be human and still keep continuing to live, trying to be human in these spaces? But I think that's the start, as you rightly pointed, to ask these questions. And I think that's where it goes back to the way at least my quick answer always, right, at this moment is like, we need to start naming this, to recognize this as the problem, and we need to address this and take it as, it's like, it's one part of a politics of appeal, I would say it as. One strain. There are multiple ways we need to bring this. Journalists should do their shared job, academics should do, doctors should do the within systems. So many ways we have to work through this, I would see it as. Yeah.
I think the only area where this is talked about, respect and dignity, is in maternity, where the conversation has sort of begun over the last 10 years. But it's only centered there. It does not talk about the everyday indignities across the whole systems, in ICUs, in wards, in OPDs, waiting. So there's no conversation about the overall oppression and indignities that patients are facing.
True.
And I think Supriya talks about that micro inequities that no one really talks about in one of her articles as well. So I actually have a question related to your article, and I think it connects very closely to the initial themes that you were saying, that you were talking about, in terms of the difference between respect for autonomy and really respect for persons, which very closely relates with dignity, right? Because I think autonomy in bioethics is a conversation that has been now criticized quite a bit and critiqued from different sociocultural aspects as well. What does it mean to be an autonomous person, right? And how does one enable agency? Because agency in itself is a very contested topic, and as a concept, it's very nebulous as well, right? In terms of how can you describe agency? There's no concrete way to kind of measure it. So it's everything and anything kind of thing, right? So how do you reconcile that particular thing? And I'm alluding to one of your articles that you wrote while you were in Zurich. So the conversation about autonomy and respect. Yeah.
I think I mean, at least the more I'm thinking after that backwards, I think we all evolve in different ways. And I think for me, evolution came from like after that time period, reading and engaging with Kant. is what that article did to me. And then my last chapter is what the more unlearning has done to me. If at all, if you see the change, definitely you will see the change, the way I think about the questions of agency and resistance again, and the idea of respect and recognition is at the heart, but much more centered around looking at the social and political recognition. So a patient's rights and dignity cannot happen if we don't address the largest social justice and especially freedom at the heart of our everyday life. That's how I would see and connect. And within the healthcare spaces, I think it should happen. And I think my immediate thing is about experiential aspect, because of much of my work is looking at the experiential lenses and embodied experiences, right? So it's looking at if a doctor or any healthcare professionals meeting another patient, how do we make sure we are not always judging a person, or definitely we are always judging because we are the evaluative beings, right? We constantly assess each other and we want to constantly categorize and mark each other. But how do we make sure, especially with people with power, healthcare providers with power, when you're treating a person, how do we make sure you or we in a way acknowledge that this treatment can come through because of this larger institutional authors? One is like awareness and reflective practice, and the way we understand autonomy for me is, again, going back to, for me, I don't want to just talk about autonomous decision making. I want to move away and step away from the decision making to look at how this decision making in the first place doesn't happen because of you're dehumanized. You don't see them as a person to talk to, because you don't see them as a knower, that idea of epistemic injustice, if you want to say. You don't even see them as a person to talk to because they don't know. What do they know? I think, that's kind of a narrative. I think we need to switch away from that and move towards the idea of self-respect and recognition. I think that's at least my understanding. Yeah. I think there are so many questions. Neelam, do you want to ask? I keep getting, sorry, I'm very bad at doing multiple tasks. I can't read chat, but I did see some of the chats coming only directly to
Are those
me.
questions going to you directly, Supriya?
Yeah, I don't know why.
Yeah, I
So
think that's why we are not able to help you with that.
Can you
Oh, so
open the chat?
so the question can be put in the entire chat box, because I'm moderating all of the questions and I'm fielding them, like I spoke about
Okay.
Asmat's question.
Thank
So
you.
if
I'm
yeah,
trying
so
to see if I
I'll
can
field that
change. I'm
for
unable to.
Supriya, because we can't expect Supriya to give intellectual input if she's reading
Oh,
chats
wait,
as
sorry.
well.
Yes, now, Neelam, now I think you should be able to. Can you see now? Okay, I hope. But or please feel free to unmute yourself and ask. I'm
No,
so sorry.
so Neelam actually asked the question,
Mm.
and if she doesn't want to, but she's asking, were you able to get any inputs from patients and or doctors from the armed forces, if not active officers, soldiers, families, at least from retired ones? Which is a
No,
very
I'm so
interesting question.
yeah, it's an interesting question. And also, no, I haven't. So far, when I discuss I mean, at least the questions which I had were much more in very pretty much who were serving within this, would you call it civil? I don't know. But they were practicing. But I've never asked them their past experiences. I didn't ask their whole journey, because I think, again, this is the limitation. Sometimes I feel like how qualitative researchers, we don't look at the whole stories of people and histories of people, where they come through and think through, and it deserves each one, which I didn't do. It's much more of that 1 to 3 hours maximum having conversation, and much of the conversation were more around that moment of information and the larger healthcare experiences. I didn't know during that time. I didn't. Sorry. Yeah. Oh, you're muted. Sorry, Swale.
Oh, sorry. Yeah, so we'll take a question from Ritash, because their hand was up, and then we'll go to Priya, who mentioned that she does have a question. So unless anyone else has a question, we'll just take these two questions, and then we'll pause, and then we'll finish, actually. Yeah.
Yeah, thanks, Sualeha and Priya. That's what I thought. We can keep our questions to the last because we can, always interact with Supriya later. But anyway, yeah, this is more of a point, apart from, again, appreciation for your book and everything. Hello?
Yeah,
Oh, sorry.
we can hear
Yeah,
you.
something happened. Yeah. So, also, the people who accompany the patient or client, as Dr. Sanai Asif from the thing keeps using, because even I don't like that word very much. So that also is an issue. Like, I mean, for us queer people, trans people, whether, especially if they can perceive what is our identity. Okay. So they will either, want to ignore us or think that we are the persons who are coming for a treatment. And usually it has to be either mental health or HIV. It can't be anything else. And more still, you can't, yeah. And also, which I've seen with my mother, she's an elderly person, but her brain is working. She remembers her organic chemistry, which she taught and studied some 60 years ago. Okay. So, and she's multilingual. So if I ask them to address her, okay, they will not. On one side, they'll be like, oh, all this and stuff, and then they will not. And like I said, no, so there's so many of these contrasts, as you say, the more the obvious social markers, which somebody might perceive as a marginalization or not. And also, of course, and unfortunately, like you said, in that government cancer hospital, what happened? Fortunately for the person, the oncologist survived. Otherwise, this person, so would have been, like would have been very bad. And the other thing, when we were reading the book, also we realized that in that Supriya, sorry, it's Samira Kohli case. I'm just getting confused with the names. That person, the husband to be, was a colonel or is a colonel retired now. So, that whole patriarchy was at play, plus his position. So I just wanted to add this because, these are things which stood out for me in the parts that I read. So, and also add, and then again, invisible disabilities, if you have, why are you cribbing? And are you the patient? Or, like, so many of these things keep coming out. And this whole South Asian culture of deifying the doctor, right? Yeah. So, how dare you? Right? This person is saving somebody's life and stuff like that. Even in a corporate hospital, even on one side, you're paying through your nose because you don't have anywhere else to go, or sometimes, unfortunately. Yeah. So
True.
just wanted to say all this. Thank you so much again. Fantastic book and very, very
Thank you,
enriching and
Ritesh.
inspiring. Yeah.
Thank
So
you,
we'll
Rita.
we'll take the question from Priya in case anyone does not have a question. Sonali was like shaking her head. I don't know if it was in disagreement or agreement with what Ritash was saying, but you can put your comments in the chat box if you have any.
That's a funny thing. We were talking about language and communication. And yeah, I have a colleague here, Nisha, who had a question. I think she sent it to Supriya in direct chat. So I told her to either just put it on the main thing. I think her hand is up, so she can just ask the
Yeah, that
question.
would be helpful. Yeah. Sorry, I'm so bad at even with my students when I teach, I'm like, sorry, let me, yeah. Thank you.
Yeah, go ahead, Nisha. Yeah.
Sorry, I just didn't want to interrupt the conversation. So I had put it in the chat box, but I'll just repeat what I said. So I'm an environmental studies scholar, and I was curious because the discussion is so interesting. I wanted to know whether any of the illnesses or any of the conversations touched upon anything related to illnesses related to environmental pollution, because I wanted to understand if you could identify or maybe see a pattern in specifically environmental illnesses getting ignored by doctors regarding marginalized communities, whether it's women or children or elderly.
Right. So this is an interesting question. And during my conversation, the reference to anything around place, not necessarily environment, I would say anything. I mean, environment and place definitely a larger unpacking one has to do. But much of the conversation on place, that is, they're locating patients from certain locations, right? Like they're trying to say these patients are from these places, whether it's in the Cherry that is in the slum area, which is nearby. And these people I know what their illness is, and they keep wanting attention. So there are certain narratives, it keeps coming up, they keep coming, one for the attention, but they also are aware they're coming from a certain location which demands you to reflect on water or in a certain, the kind of illnesses which creates because of the larger environment which they live in, which they're aware, but they want to stigmatize a group because of exact reason, right? And I think that's my biggest problem with how you treat a patient based on different markers, and one of them is the location where they are situated, and not looking at patients' histories, which is located based on the location and the larger environment one is in, but I'm not listen to stories explicitly about the environment in relation to illness, but the references to location and the larger discriminatory patterns is clearly, I would say, is part of the discourse. I would see it as, and I did notice, and a couple of them have captured here and there in the work.
Yeah. Okay. Thank you. Thank you. That's fascinating work that you're doing. Thank you.
Thank you, Nisha.
Thank you, everyone. Like, we're so happy, and Sualeha were talking about it, the personal chat, that we're so happy that so many people have come in who have not come before. So we were really worried that because we had to take that hiatus because of socio-political situation. But we're very happy that there are people here who might not have come before. So that really makes my heart warm. So, and in the end, Supriya, thank you so much. Of course, Sualeha will do her formal vote of thanks. But my last question is, because we did talk about methodology a bit, and you have mentioned while speaking that, your own experience. So the motivation to write this book, Supriya, has been your own experiences, right? You write about growing up, you know, uh, in not so privileged condition, coming from a community, which is indigenous. Uh, you write about your cousin, a very poignant story, who couldn't make it because of medical, negligence or not the same disrespect and other things. So, how I know it's a personal endeavor for you, but somewhere I don't know if it was your father or who says that, what will this book do for us, right? So I would want you to end with that. Like,
Right.
tell us something on that.
Now, okay, before I answer that question, I have been really enjoying thinking through and then engaging with these questions, Priya, particularly for you to, very carefully engaging with my work and thinking through these questions. So thank you for that and for all these questions. I know I will thank you again officially before we end. But this question is particularly really a thing which is at the heart for me, because every day, you as academics, the more you ask, like, what is this writings for and who are we writing for? And to be honest, I am really torn, because the more I'm working right now, I'm working with my own community. So back when I was doing this research during my PhD, it's still part of the larger community, but based on the lived experience and witnessing. It's like constant witnessing of this is what I drawn me to reflect more. And this is my third or fourth attempt, as I think I say in my preface. It's like I'm trying to find my own voice as an academic. At the same time, how do we channel the kind of experiences or rage or anger or whatever experiences one carries to what cause? And again, to be honest, I'm not saying this book would do anything, but I really hope this is just a conversation and a contribution for ongoing resistance, because there's so much of resistance happens which we need to more acknowledge, and we see this. I think that's the part I would see, and this book is more of a conversation starter. I hope this book would be. And to be honest, I still work much more when privileged. I'm so privileged now, and I'm so in this bubble of academia, and I'm asking myself question the more I'm working right now with my living in Sydney, but at least in a year, 2, 3, at least 4 months, I come back to India, right? At least last year I did, and next year I'm going to come back. Now, this idea of coming back home is, and I work with my rural communities in Nilgiris, and also living with my parents when I'm there, and we live in. I mean, I'm not yet rich to take away the poverty from my parents, so I live in the house, which is still, it's difficult, like, the social housing kind of a situation. Imagine that kind of where you don't have ventilation, you smell the, yeah, well, it's like I mean, the people who live with this certain different phases of poverty, you want to get away from it, but I want to go back. And now I am asking myself what this writing's for. To be honest, I don't know. I'm struggling with this, because on one hand, I want to move towards organizing more and then joining the moments. But again, the idea of joining the moments is not very perfect, and it demands more. And do I have that capacity is one of the questions. And is where because I think so far I've trained myself into listening stories of suffering, and I think that's what the book is about. It's like listening to the stories of suffering, capturing and then naming them and theorizing, and hoping that it channels where hopefully some judge one day reads, hopefully some healthcare professionals read somewhere and then reflects these practices and not take for granted these experiences. And yeah, so it's like there are so many hopes and there are so many expectations. But to answer my dad, what does it do? I really hope it does something where we have basic minimum healthcare. We have no caste discrimination. I know it's like a big ambitions we all want, right? We want to live in a country or a society where the oppressive conditions doesn't dehumanize to this extent. I mean, I was watching this Homebound, and it's so my partner and we were watching together. The things we watch, it hits people differently at different for because of lived experience and different, right? And then I was thinking again, what am I writing this for? What the hell? That I keep coming back to this every day, to be honest, especially living here and with the privilege which I carry now. And yeah, I don't know. It's an ongoing conversation, I hope.
Yeah, and before I give it to Sualeha, we did not even touch upon the fact that you are right now abroad and battling another form of hierarchy where you're now suddenly a brown person, right? From global south who has all the, responsibility on her to do, you will be the DEI person for them. So I know this is another ball game and another battle altogether, but thank you for doing the kind of theory that Bell Hooks asked us to do. So I'll just end with that and I'll give it to Sualeha. Thank you
Thanks,
so much.
Priya.
So I think thank you so much, Supriya, for being so honest and candid with your learning and unlearning processes. I think it takes a lot of courage, as Dr. Shahid is rightly saying from Pakistan, that it does take a lot of courage to come out and talk about these things, especially within cultures like Pakistan and India, where physicians do enjoy a lot of power and prestige. So I can understand that you woke up to a lot of angry emails and stuff, and that takes a lot of bravery as well. One would not think that one would get a lot of hatred on this particular aspect, but clearly people have a lot of free time. But as you can see, and I mean, I'll echo what Priya was saying in terms of you're theorizing, and I think that's important. In terms of, I was reading about how theorizing is a liberatory practice, right? And I think we're all doing that, right? With this conversation. Thank you so much, everyone, for joining us and for making this such a great conversation. And Supriya, always a pleasure to learn from you. And everyone, we will be now hosting events more and more often now that things have kind of mellowed down. So thank you so much, everyone. And yeah, that's really it. Please join us on LinkedIn. We post all our events on LinkedIn. And yeah, I think that's it.
No, thank you so much. I mean, I just wanted to say especially thanks for being here and engaging, because on one hand you feel you're not seen as a scholar to be engaged with from this part of the world where right now I am in. No one engages because there's something India discourse. That's how they see my work. And then again within Indian communities, not much works have been engaged. So it feels really valued that you're all here, and especially as I enjoy listening and asking these, the questions, especially Priya, all of you have made me think through more. And hopefully we'll continue these conversations more and more. I think that's what we
Actually,
want.
so I've assigned parts of your chapters, etc., for readings as well.
Oh, great.
And I've told that to you before. So I think it will eventually. So like in terms of the audience that you're writing and who are you writing it for, even if it is an academic audience that you're writing for, the academic audience can translate it into practice, because theory is very important before you translate things into practice.
True. Thank you. No, thanks once again for everyone for being here and for all your kind words and for the questions. Thanks, Priya, Sualeha.